There we go. Well, I'm very, very excited about today's event, and I'm welcoming all of you to our first annual Dean-sponsored colloquium that's hosted by the Center for Excellence in Collaborative Education and co-sponsored with generous support by the College of Osteopathic Medicine and the Office of Diversity, Equity, and Inclusion. The Dean's Colloquium is designed to bring issues of the day to our students and for us to have an opportunity to hear from experts and to talk with each other and learn from each other about these topics. Today's colloquium, we will be presenting on prejudiced patients, caring for those who discriminate against you, the provider, which is no doubt a very, very timely topic. Your host for this inaugural Dean's event is Dr. Dean Robert McCarthy, who will be making his remarks soon. He's the Dean of the School of Pharmacy and Associate Dean of WCHP. I think Chris already mentioned muting your mic, but I'm going to really invite you to get your videos on because our speaker would like to see you, and you are going to really like to see her. Our speaker is Pooja. I'm gonna blow this, I know, Pooja. Chandrashekar would like to see your audience. So it's now my great pleasure to introduce Dean McCarthy. Take it away.
Thank you, Shelley. Good afternoon. I'm pleased to welcome you to this afternoon's critically important and very timely colloquium, Prejudiced Patients, Caring for Those Who Discriminate Against You. The idea for today's event came from a former UNE dental hygiene faculty member who had witnessed discrimination by a clinic patient toward a Muslim student wearing a hijab. A School of Pharmacy Latino student reported similar acts of discrimination. These patients' refusal of treatment were based on prejudice. At UNE, we are committed to cultural humility and to making our university a welcoming environment. This incident, among others, reinforces our belief that we must prepare students to respectfully manage situations of prejudice in their clinical and community settings. We are thrilled today, very fortunate to have with us Pooja Chandrashekar, a joint MD-MBA student from both Harvard Medical and Harvard Business Schools. As she will share, her first interaction with a prejudiced patient occurred quite early in her career as a medical student. Pooja is passionate about providing quality health care for vulnerable, underserved populations. She is the founder and CEO of Project CS Girls, an international nonprofit organization dedicated to encouraging middle school girls to pursue education and careers in STEM fields. Pooja's work with the NPO earned her the Harvard Medical School Dean's Community Service Award. Her own experience with patient prejudice has led her to collaborate with Dr. Sachin Jain to develop programming to assist health profession students and practitioners in dealing with patient bias and discrimination. Today's program is designed to be interactive with live and online audiences. Assisting Pooja today is our own Ed Silver, UNE's Interim Associate Provost for Diversity, Equity, and Inclusion. Please join me in welcoming Pooja Chandrashekar to the podium.
Thank you so much, Dean McCarthy, and good afternoon, everybody. It is such a pleasure to be here today and an honor to share this space with all of you. I just want to start by thanking the entire University of New England team for the opportunity to be here and speak with you all today. This topic, the one of prejudiced patients, is one that's long gone unaddressed and is often swept under the rug at healthcare organizations and academic medical centers. So it's really wonderful for me to see the University of New England shed light on this important topic and see how this university is making sure everybody, health profession students and faculty, can come together and have the space to talk about this issue and come up with solutions together. As Dean McCarthy said, my name is Pooja Chandrashekar, and I'm a current MD-MBA student at Harvard Medical School and Harvard Business School. Next slide, please. Before I dive in, I just wanted to give you all a taste of what lies ahead in our next hour and a half together. So our objectives today are one, to understand how patient bias and discrimination manifest in the clinical setting, the ethical dilemma these topics present, and the impact it has on clinicians, especially those from minority backgrounds. Second, to give you a framework for how you might react to these issues when confronted with them in the moment, and also how you might think about them after the incident occurs. Often when this sort of abuse happens, it leaves the victim feeling shocked, embarrassed, and helpless. And in those moments, it's really helpful to have the muscle memory for how you might want to think about and react. So hopefully you can come away with some very actionable frameworks. And finally, alongside the individual response, it's important to also think about the institutional response. So we'll spend some time brainstorming some ideas together that you can take back to your department and institution. And I want to emphasize that today is really going to be about all of us learning together. I'm going to have some didactic slides and give you some key take-home points, but I really want to use this next hour and a half for us to learn together, engage in a vibrant discussion, and really tackle these issues head on. So we'll have two cases with breakouts for each case, and then a chance to debrief, share our learnings, and be in conversation after each. So I hope that in this next hour and a half, you'll take the chance to be honest and open and vulnerable, and also respectful towards others with viewpoints different from your own, because this is an issue that can become divisive. Great. Next slide, please. Great. So to set the stage for our discussion, I want to start by sharing how I came to this topic personally and why I feel compelled to do this work as a medical student. So during my first week of medical school, all of us in my class were assigned to read this paper called The Racist Patient, published in the Annals of Internal Medicine by Dr. Sachin Jain. And Dr. Jain happens to be a longtime mentor of mine and also a collaborator. And in this piece, he delves into his first interaction with a patient who exhibited racist and discriminatory views towards him. So as a resident at Brigham and Women's Hospital, Dr. Jain was asked to see an angry patient who commented that "you people are so incompetent," referring to his Indian American ethnicity. He treated the patient with utmost respect and asked if the patient would like him to come back later after he'd had a chance to cool down. But the patient angrily retorted with, "Why don't you go back to India?" This incident triggered painful childhood memories of racist taunts in the school playground for Dr. Jain, and he responded on instinct with, "Why don't you leave our expletive hospital?" He left the room, spoke to his attending, and later absolved himself of caring for this patient, who was switched to a different clinician. And I want you to keep this scenario in mind because we will come back to it later in a case. Next slide. So that was my first introduction to the issue of patient bias and discrimination. Because before that time, before reading this paper, I honestly didn't know that these things could happen in the clinical setting. Of course, we're all very well aware of how prevalent racism and discrimination is in general in society, but often we don't think about how these issues occur in the clinical setting and the impact it has on us until we are actually confronted with them. And as with many issues, you don't understand the magnitude or the emotional weight of that issue until you experience it yourself. So Dean McCarthy referenced this in his remarks that I was confronted with this issue pretty early on in my clinical training. And I want to share that story as well. My second time ever seeing a patient, a couple months into my first year in our practice of medicine course, where we're learning the skills to practice clinical interviewing, I was introduced to this patient in the hospital, and I was asked to interview him. We proceeded through the interview with no problems, but when I got to his family history, the patient launched into a tirade ridden with racist taunts about how much he hated Koreans and Vietnamese people, how the nurses at this hospital are too fat, and how people need to stop coming over the border and ruining this country. And this was when me and another student were in the room. Myself as a child of immigrants and my fellow student who is of Asian American descent. And unfortunately, my preceptor, who was very well-meaning otherwise, said nothing. I was confused, at a loss of words for how exactly to react to this. So I ended up thanking the patient, ending the interview. And actually, when I left the room, my preceptor didn't bring this issue up to me. So I actually had to work up the courage to bring it up to him and ask, what did you think about this? Am I crazy for thinking that this is not something that should be happening in an interview with a healthcare professional? And how do I actually address these issues in the future when they do occur? Unfortunately, I didn't receive much helpful information from him or from the other faculty members I spoke to about this topic, likely because they didn't have the training or resources to talk about these issues in a systematic way with students. And that was really what propelled me to begin thinking about this issue and began thinking about how can we educate not only students, but also train faculty members and propel institutions to take action on this very important emotion-laden issue. And before I jump to the next slide, perfect, I want you to put in the chat, if you feel comfortable sharing, have you yourself experienced incidents of patient bias? And share those with each other in the chat so that we can get a sense of how these issues actually manifest in the clinical setting. All right, so let's unpack this issue a little bit more and think about what is the actual ethical dilemma that we're seeing here. Why is it that these issues cause so much mental torment for us compared to other issues, even other issues of workplace violence? Why does this issue cause us to feel so many conflicting emotions? So the reality is that the duty to care for all patients, regardless of beliefs or circumstance, is central to the medical professional. It's part of the reason why we all came here to do what we are driven to do, to heal people of all backgrounds. We live by this ideal that patient preferences should guide all clinical interactions and decisions. And so with that, there's this implicit expectation that clinicians should care for patients no matter what their behavior is. But clinicians also have the right to a workplace free of mistreatment and abuse. And that's the ethical dilemma here. How do we reconcile our respect for patient autonomy and the expectation to always put patients first with the basic right of clinicians to be treated with dignity and with respect? Right now, during health professions education and training, as we saw from Dr. Jane's response that he wrote about in The Racist Patient, and my own experience as a first-year medical student, clinicians and students receive little instructions on how to answer this question, and few healthcare organizations actually have those clear policies or procedures to guide staff in responding to these incidents when they inevitably occur. So that's the central question here. How should clinicians respond when patients exhibit biased behavior? And how can healthcare organizations develop policies to mitigate the effects of these experiences? And that's the issue we're going to be delving in today. All right, next slide, please. So we're going to now jump into our first case, and you'll have 10 minutes in breakout rooms to think about this topic. So I want all of you to put yourself in Dr. Jane's shoes. If you were in his situation where a patient told you to go back to the country you came from, how might you have responded? And apart from how you might respond in the moment, think about what actions you might take outside of the patient encounter. So what might you do after you leave that clinic room? So I want you to kind of think about this question, share experiences with each other, feel free to disagree, and come to some different points and different experiences. So we'll put you into breakout rooms right now, and we'll come back. And if you could indicate one person in your group who might be willing to speak up on behalf of your group and share what you all talked about, that would be great. If we might call on you afterwards. Thank you all.
To share. So I'd love to get any feedback, maybe from this group right here. Do you care to share? And if you could give your name, then that would be great.
Hi, I'm Victoria, and in our group we talked a lot about what you'd said in similar situations, like if you're in a rural emergency room, there's not many doctors on hand, the patient is in critical care, And ultimately, what we decided would be our approach, and what we were talking about was we'd give our patient realistic options and work on grounding them. So we'd say, I understand that you don't want to receive care from me today. These are your options. You can receive care from someone else, or you can continue in my care. And we also talked a lot about the idea that we deserve a safe environment to practice in. And this has come up recently, and there should be protocols, and in many hospitals, there are protocols to provide us with that.
Thank you. Thank you so much. How about one more group over here?
Hi, my name is Connor. Our conversation really started on the macro level using the first part of the question, just trying to put ourselves in Dr. Jane's shoes and how we might have reacted in this situation. And I think all of us kind of agreed that, it's very difficult to try to imagine what Dr. Jane was feeling in the moment, and how, we all agreed that trying to meet the patient where they're at, trying to treat the patient with patience and with respect. But ultimately, we don't blame him for how he ultimately reacted. And I think removing himself from that situation was the best thing that he could do for himself, and how we didn't disagree with that. But similar to what Victoria said, I think our conversation really got very philosophical, and we started thinking about healthcare on a more macro scale, and how patients, really have the sense of entitlement because of this, the customer is always right mentality, and how this is a product of consumerism in healthcare. And I love what Victoria was saying about providing the patient with options, and moving forward with their healthcare with the perspective of this is a team, and you're going to get out of it what you put into it, and however you engage with me is going to directly dictate your outcomes. That's sort of the conversation that we were having as well.
Thanks. That's great feedback. We got time for maybe one more group over here in our group. Anybody over here want to report back? We got over here? Okay, perfect. We got one right here. Just give your name and kind of give us your feedback. Thank you so much.
Sure. Hello, my name is Amelia. In our group, we talked about how the burden to either confront the patient, the burden to confront the patient shouldn't always be on the victim in the situation, and that the hospital or the place of work needs to look at setting up support systems, someone who can go in there and help facilitate a conversation with that patient, but not to put that burden on the victim in the situation, who is working, who is busy, and when it's pretty clear that the patient is not in the right emotional, physical, or mental state to have a grounded and emotionally intelligent conversation at that time. As higher level providers, it might be more difficult to switch out at times and find another provider for that patient. So looking at other people who can intervene at that time.
Absolutely. Such great reflection.
One of the common themes that we're seeing then, right, is that there needs to be some systems of support in place here. And that, there's obviously some cultural changes that need to happen. I think your point that you made about the customer's always right is a great perspective to offer, and really creates a lot of pressure. But I think what you were talking about in terms of just taking that burden off the victim, we know you have this, this responsibility to care, but at the same time, we're in this environment where, you don't have the responsibility, or the person doesn't have the right to kind of harass you, and what things are in place.
Absolutely. Such great reflections all around. I'm just going to try to highlight
feedback.
Yeah. So just to highlight some of those further, so that this concept of the customer is always right mentality, so important. And something that we need to be thinking about is, how do we balance that mentality, or how do we change that mentality when these kinds of incidents really cause moral injury, long-term psychological damage as they accumulate and build up? And how do we mediate those effects in the long run? Another idea here is the concept of faculty and institutional support, and that the burden should not fall on the victim. Something that often comes up in these conversations is, should we be educating the patient here? And should the victim be doing that? And the answer is no. Educating the patient or asking the victim to educate the patient is almost akin to blaming the victim. There can be another person on the team whose responsibility or who can take up that responsibility to educate the patient. But in that moment, we really need to think about the moral injury that's caused to the victim. And finally, I love this idea of offering different resources and offering different options, and recognizing that the emotional impact is different for each clinician, and that it's really hard for us to put ourselves in somebody else's shoes without realizing, all of the history and trauma that goes into somebody's instinctive response. Great. So next slide. Great. So I wanted to give you all a distilled version of our framework for responding to biased patients. So a lot of these ideas actually came up in our discussion, which is great. But we recommend that clinicians really begin by assessing 3 characteristics right off the bat. First is their own safety and well-being, which should always be a priority, as we just talked about. The second is the patient's medical condition. And somebody in your group had also brought this up. Are they in need of emergent medical care? Is their condition critical? Is their decision-making capacity intact? And what are the resources available in the particular setting in which this incident occurred? And the reasons for a patient's behavior or a request to be reassigned to another clinician are varied. And I do want to highlight that there are some legitimate and reasonable reasons why patients might act a certain way. This can include a history of discrimination within the healthcare system. It can include past trauma. So it's really important to try and understand why the patient is behaving this way and whether their actions convey an intent to hurt or shame the targeted clinician. Next, moving on to the ACT part of our framework. So we see these first 2 up here as immediate responses. So if the clinician feels unsafe at any time, they absolutely have the right to exit the encounter and transfer care. Or if the patient is unstable, medical care should likely take priority in those settings. Otherwise, we need to then determine whether the patient's behavior is ethically justifiable. If yes, then we might be more inclined to accommodate or tolerate their behavior. And if no, then we should think about expressing our discomfort. And then depending on the nuance of the situation and the resources available in the setting at hand, we can engage in negotiation, persuasion, offer those resources, those options that we talked about, and if needed, transfer care. And following the incident, we should think about, what do we do after this incident occurs? It's not enough to just think about what do we need to do in the moment, but also what do we need to do after the incident. So we think you should inform supervisors and administrators, report the incident, and then document the incident in the patient's chart. Now, this is a tricky one. So if the patient was delirious or had legitimate reasons why they acted a certain way, it does make sense to include that context when you're documenting it. But if the incident happened, it happened, and that was part of the clinical experience. There also importantly needs to be opportunities for clinicians to reflect on what just happened, debrief with the team, and turn what is a painful, profoundly degrading experience into an opportunity for professional growth and learning. Next slide. So some take-home points. So that was a lot for this framework, but I just want to take a step back and what can you take away from this framework? So first, these experiences can absolutely cause moral injury and accelerate burnout, especially among minority clinicians. Second, if you feel unsafe, exit the encounter immediately. Third, there are a few situations, so emergencies, no alternative provider, and others in which you may prioritize treating and stabilizing the patient first. But in other situations, it's important to think about acknowledging your discomfort. And I put some example language up here as to how you can do that, because oftentimes the response that I get is, okay, so you acknowledge your discomfort, but how do you do that in a way that's respectful towards patients, doesn't immediately damage your patient-doctor or patient-clinician relationship, but also expresses what you are feeling and what this patient's actions or behaviors did to you. So some language here that strikes that balance nicely, I think, is up here. Importantly, recognize that you should not tolerate abuse and that you deserve to be treated with dignity and respect. Next slide, please. So now for our second case, we're going to be discussing the impact of patient bias on trainees. I saw some chats popping up about how it's difficult to do this as a student, how it's difficult to do this when you're kind of at an uncomfortable position in the medical hierarchy. And, I am in this position as well, so I can definitely relate to that. So we're going to think about this issue and how it specifically affects trainees and how faculty members can support trainees when these incidents do occur. So trainees are particularly vulnerable to patient bias, and there are many reasons why we are more vulnerable. This includes a lack of knowledge on handling such situations, position in the medical hierarchy, the lack of decision-making authority, concerns for supervisors perceiving us as weak or flawed, and the potential repercussions that we perceive on our grades, how we fit into the team, and thus the effect on our clinical evaluations. But these also have very real and tangible impacts on us as students and on our ability to learn in the clinical environment. It can lead us to have a decreased ability to focus on learning and training. It can lead to trainees feeling devalued and invisible. It can lead us to avoid rotations in clinical sites where it's known that encounters with biased patients are more common. And this is something that I've certainly talked about with my medical school classmates. And perhaps worst of all, it can lead to this kind of learned helplessness that this is just part of the job and that we need to suck it up and keep moving on because this is just how things are, and that this is our early introduction, but this is just how it's going to be for the rest of our careers. Next slide, please. So this brings us to case number 2. And this is a real case that happened at the University of Virginia when Claire was a medical student there, a pharmacy student there, but she has now since graduated, but just to let you know that this is grounded in a real experience. So now imagine yourself as the preceptor. So you are precepting Claire, a female Black pharmacy student. She is seeing Mr. Smith, a white patient. Mr. Smith calls Claire colored girl 3 times in front of you. Claire does not say anything to Mr. Smith and proceeds with her interview, though she seems uncomfortable. As Claire's preceptor, how would you handle this situation? What, if anything, would you say to Claire? And what would you say to the patient? So use these 3 discussion questions as a launching off point to talk about this case. And I think there are a number of different facets of this case that you can focus on. The fact that Claire is a female Black student and that Mr. Smith is a white patient. The fact that this is happening right in front of you, but not necessarily to you. So how do you, as a faculty member and with somebody who is in a different position in the medical hierarchy and with the power to exert influence on this patient and on this trainee, how would you react to the situation and how would you set this person up for success, not only in the moment, but in the future? All right, so we will go to a breakout rooms for 10 minutes again, and we'll come back and talk about it.
Let Claire know that that's not okay and that this is not what we stand for, and we got your back. But Biddeford, we've really been taking a lot of this shine here, a lot of the light with our communication here. We're going to toss it over to Dr. McCarthy and see what Portland has to say.
Ed, thank you so much. Which table would like to share what they've been talking about this case? Just raise your hand. Don't be shy. Come on. This is your opportunity. All right, Zoe. I talked to Zoe earlier. She's going to say something.
Hi, I'm Zoe. So I think, our table talked about how, maybe emphasizing Claire's name just to kind of, make sure Mr. Smith kind of says, hey, like this is her name instead of, calling her a colored girl.
I think you're muted, the Portland campus.
Hi, I'm Zoe. So our table just talked about how we can emphasize, Claire's name to Mr. Smith just to see like if he, kind of gets the signal like, hey, this is her name, not to call her colored girl. I think this is a tough situation, personally. I think maybe talking to Mr. Smith and just saying, we don't know Claire's last name, but, emphasizing her last name. And I think I would talk to Mr. Smith and say, if she's a doctor, kind of representing her position as a physician and who she is rather than, her name per se.
Thanks, Zoe. Other table like to share their? Good, great, thank you. Tell us who you are and what program you're from.
Sure, thank you. Hi, everyone. My name is Belle, and I'm a social work student. And our table talked about, first and foremost, how we can't remove our identities from our profession. And so first supporting Claire as the student that we are precepting. And an example is I identify as AAPI, Asian American Pacific Islander, and I want to be able to make sure that Claire understands that this behavior is unacceptable, and that while we are going to provide patient-first care, that, like the speaker said, we deserve to be treated with respect, and this should be a safe place. And so I would gently, redirect to Mr. Smith that he's called Claire, who is a competent provider, colored girl 3 times, and the facility that we are in is one of mutual respect, and we offer him respect, and we want to give him the best care, and that, like our colleagues at the other table said, that her name is Claire, and that, if there's anything we can do to make him comfortable, but that language is not appropriate. We also talked about after the patient encounter, checking in with Claire to ensure that she feels safe and provided for, and if there is any zipping up or need for her to feel supported on behalf of the precepting relationship, but the office or the administration or back to her higher education relationship that we can do to support her, that ongoing relationship is just well maintained, and that she understands that this situation, while it might occur, is not acceptable behavior.
Thank you so much.
Great. And I just added to that, and this was a discussion at a table, that sometimes referring to people of color as colored people is generational, like people of an older generation. So there might be an opportunity, to just let Mr. Smith know that, we really don't use that phrase anymore. It's really hurtful to people, and we call people of color, or what they want to be called. So we need to listen. And then we also just spoke about how there's always an opportunity for white people to listen to each other about our own experiences around race. Tell me everything about race in your life. That's something we as white people, it's helpful for us to do, so people can process this. Many haven't had a chance to.
Jan, thank you. Time for just one quick question, comment from the table. One more quick comment. Somebody, don't be shy. Should we pick on? We'll pick on the pharmacy people over here. Yeah, 1 minute.
1 minute. So we had a very brief conversation, and we talked about wanting to check in with Claire, but also maybe not wanting to put Claire on the spot. So one of the things we talked about was, as a preceptor, you could say to Mr. Smith, your words are making me uncomfortable, and I imagine they're making Claire uncomfortable as well. And kind of trying to divert some of the attention to you as the faculty member, so that the student doesn't feel like there's as much burden or all eyes are on her, and trying to kind of shift the focus and then educate back to Mr. Smith what your clear expectations are. My expectation is that we don't use that language here because I find it to be offensive. And this is my student whose name is Claire, and I'll give them maybe one more chance and then say, otherwise, I think we should end this session. So giving them, you can do this or you can do this.
Thanks, everybody.
These are such amazing conversations and such important reflections. I'll highlight one more in the chat from Shelley's group that talked about the need for preceptors to set the stage before students even meet with patients. So I think trying to synthesize all of that, we're thinking about how do we set the stage even before an incident like this happens? How do we make sure that the treatment that trainees receive from patients are respectful of our identities when our identities are so central to how we care for patients in the first place? And then how can faculty members and institutions as a whole use that privilege to make sure that the burden doesn't fall on the trainee to speak up in that situation? And how do we make sure that they feel heard and respected and valued after the incident occurs? So, okay, perfect. Next slide. This is the right slide. Please don't advance the slide even more. So when we think about how we can support trainees in responding to patient bias, the first thing to think about is the one that we just mentioned, is when we first meet a trainee, setting expectations up front, having a conversation with the trainee at the start of your relationship with them, and setting expectations and discussing protocols for responding to biased patients. Saying that these kinds of incidents might occur and you might be confronted with them, but emphasizing that they should not continue engaging in a situation that makes them uncomfortable. Next, it's important, crucially important, for you as the faculty member or supervisor to speak up. Always err on the side of intervening when these incidents happen. Of course, it's important to recognize that different students might have different expectations for what they want their preceptor to do in this situation, but it's best to err on the side of intervening when they happen, because there's often this misconception among trainees that we just have to keep moving forward no matter what happens. This is all part of our training and our socialization to the profession. But when you do intervene, it sends a powerful message that you can model, that you are there to be an advocate for that student. And it also, when you model the behavior, the bias, discrimination, and abuse are not tolerated, it really sets that trainee up for success in the future when they do encounter a biased patient again. And it gives them the tools and the confidence that they need to navigate that situation. And in the even longer run, when they are in a position of power, they can think back to how you modeled that behavior for them and do the same for the student or trainee that they're precepting. And after the incident, make sure that you debrief. This came up in a lot of your fantastic comments, but research really shows us the value of purposeful reflection and processing and learning from these emotionally challenging clinical encounters. So following the event, make sure that you can provide that trainee with a safe space, a non-judgmental space to talk about what just happened. And don't minimize their experience, but rather support them, validate what they're feeling, and guide them in crafting a meaningful future response. Next slide. So to recap, again, I have up here some example language so that you actually have a sense of how do we apply these theoretical concepts in practice. So feel free to take a picture of the slide, any of my slides, so you can take it with you. But it's important to first set expectations, emphasize being an advocate, emphasize being able to step away, emphasize that you're available, and make sure that you highlight the resources available in the institution that the student is in. Because oftentimes we just don't know where to go to report these incidents or to seek support. Second, intervene. Show the patient, rather than using an accusatory approach to addressing this issue head on with the patient, show them how their words or actions made the trainee feel. And I think somebody had an excellent idea about, rather than directing all the attention towards the trainee, you could also show the patient how it made you feel, and say that, and I expect that this is also how you made my trainee feel. And I think that's an excellent approach as well to add on to my recommendations here. And finally, debrief. Give them space to express what they're feeling, and give them the space to ask for your help in the way that they need it. So finally, let's talk about how we might tackle this issue at the institutional level. Throughout the course of this talk so far, we've heard over and over again the importance of the institution in creating the necessary protocols, the necessary culture to allow us to talk about these issues and to respond appropriately, and to make sure that we have this no tolerance policy, so that it's really a culture of mutual respect, and that we can maintain our dignity in this profession. So I'd love for you all to put some ideas in the chat, or unmute yourself, raise your hand so that I can call on you, or somebody can call on you. And then you can unmute yourself, and we can we can brainstorm how we can tackle this issue at the institutional level.
There we go. We got Shelley from Biddeford.
So can you hear me?
Yes.
Okay, awesome. One of the things that came up in our student group that I think pertains to this question is students are quite concerned about sharing their perspectives with preceptors who they don't know will either tell them to get over it or that's not appropriate in the setting, because they don't know what their background is, they don't know what their style is. And of course, all of our students are evaluated by their preceptors or field instructors. So can you say something about that?
Yeah, absolutely. And, as a medical student myself, it's definitely something that I think about a lot too. I think there are two parts to this. First, I think, it's really on the faculty member here to make sure that the student has the space to reflect on these issues and feels comfortable speaking up, and knows that they will be supported when they do bring these issues up to their preceptors. So I'd say that's part of the issue here, is that at the start of a relationship with a trainee, right now, we often don't talk about patient bias or discrimination and how that might affect the trainee. So making sure to bring these issues up at the beginning of that relationship is the first approach. The second piece is, I would say that, yes, you may feel uncomfortable, you may worry about the repercussions on your grades or evaluations, but remember that you're in this for the long run. We're all in this for the long run. We have a, decades-long career ahead of us. And yes, you might want to fit into the team right now and do the things to fit into the team right now. But there is a cost to doing that. There is a cost to your moral consciousness. There is a cost to your psyche when you allow these issues to continue to fester and to affect you. So I would really encourage you that you should feel empowered to speak up, even if your preceptor doesn't bring this issue up to you, even though they really should.
Thank you.
Great. So I'm going to turn. Yep. So sorry, go ahead.
That's okay.
All right.
I think we're back. My name is Mike Sheldon. I work in the provost office, but I'm a physical therapist. And if we're talking about institutional level response, I think it's important that we all understand that most clinical preceptors don't get a lot of orientation training themselves. They just get thrown into the role of being a preceptor based on years of experience or maybe their clinical expertise. And I think at the institutional level, it's important to actually provide, to me, the parallel is in higher ed. A lot of folks that are providing education in their discipline are again, they're hired because of their disciplinary expertise and not necessarily having the background in, the best pedagogy and how to be a teacher. And here, I think there's a lot on the institutional level that could be done with preceptor training, and this being embedded as part of the training.
Absolutely. Education is a critical part of this, not only for students, but also for their preceptors and their faculty, which is, I think, an event like this is so important, where we're bringing together not only students, but also faculty members to talk about these issues, because oftentimes we talk about them in silos. Anybody else, you can just
Hi there.
unmute yourself and go ahead.
Hi, this is James Krebs on the Portland campus, and I think a really great strategy that we implement here and other universities could do is using simulation. So if we can practice these in a controlled, safe environment, it gives the students some strategies on how to effectively do it when they're out in the real world. So yeah, it's going to make our students feel uncomfortable, but we'd like to do it in a safe environment. So I think that simulation is a great thing to do.
I love that. Absolutely. You know, we do OSCEs for all sorts of clinical encounters. Why not also for this very important, potentially emotionally damaging one too?
Mary Obey from the Dental Hygiene Department. It's good to say we do need to do training for our preceptors, but I was actually involved in the incident in the Dental Hygiene Department, and I don't feel we were backed up by our higher-ups because they don't experience what our students go through. Mm-hmm. They're not on the direct floor, the direct contact with the patient, with the student. So I don't feel like, I think we need to have more of a protocol for faculty like myself to be able to report it and be respected. And because I feel that our faculty member who was involved in this did do exactly what she needed to do, but I don't feel like she was supported by the higher ups because they weren't there and it was hearsay. So I think there's got to be a direct protocol by the higher ups and not a wishy-washy kind of thing. It's got to be an answer, and that faculty member has to be able to be respected in the decision that he or she made for their student.
Absolutely. It really has to start from the top. And I think another important part of your comment was how the leadership affects the culture of the institution, and allowing, building a culture that, you know, makes everybody feel safe, but also allows for reporting and for discussion of this very important topic so that not only students, but faculty also feel empowered to support their own students.
I have one other comment. This is Emily from the Portland campus. It gets back to that, which is institutional protocols. You know, we have a lot of different colleges with a lot of different health professions present, and each one handles student placement very differently. But because of that, it's very easy to lose track of how reporting might occur. So I think from an institutional level, thinking about who in the institution do these funnel to in a way that's meaningful, and then also once those reports are made, what is the follow-up with the student and the faculty members so that we can offer, because we might have students in different states, we might have students with people who are not, you know, as Provost Sheldon said, not trained to be great clinical preceptors. So what can we do as an institution then to be able to push resources back out to those students, to have support services or counseling services reach out to them and assist with a debrief, because that trauma might exist for many weeks thereafter if they have to continue to go back to that site. So, you know, there's lots of things besides just the handling of the initial incident that occurs that I think we should be thinking about it as an institution.
Absolutely. That piece about follow-up is so critical, especially because, you know, for many students and trainees, they may not want to speak up in the moment. You know, it just, enduring that sort of trauma might mean that they would rather take action afterwards, like you suggested. So if we create some sort of process where they can submit their experience or feedback, then we also need to create a process that acts on that feedback. I can tell you from my own experience at HMS, we do have an institutional system whereby students are encouraged to report incidents of patient bias, but we actually don't really have any sort of follow-up system. And it's a problem at the institutional level. They just kind of go into a black hole, and then we never really hear from them again. And potentially, you know, we'll occasionally get reports of what these incidents were about, where they occurred, which hospitals they occurred at. But there's not that individual level engagement with the student that submitted that incident in the first place, which is critical to actually creating change.
Pooja, I have a great question or comment in the chat from Provost Pardue. I don't know if you want to light yourself up or whether you want me to read it out, but it's really about the relationship between the student and the preceptor. So I guess I'll just go ahead and unless I see Provost Pardue.
Well, I'm happy to speak to it.
Good.
It was my experience in being a preceptor, but I also did this very often in the classroom with students at the very first meeting to say, you know, as part of this relationship, I'm going to be giving you feedback, but I really invite you to make observations or give feedback to me. And if you establish that type of exchange of information really early on, then when situations like this come up, you as a student at least have in your hip pocket, remember what we talked about on that first day? So here's what happened today. And it opens the door in a very comfortable way to be giving feedback. And so with a student hat on, I might say on my very first day of precepting, you know, I expect that I'm going to receive feedback from you. I hope I have an invitation to offer my observations when things arise during this rotation. And if you make that agreement early on, then as things come up, it just gives you something to open the door, because that's been my experience. It's hard sometimes to talk about these things and to figure out how to initiate that conversation. That's the value of what Dr. Krebs offered with simulation, because you can do this cognitive rehearsal and practice what might we do. But if you're on the fly, if you've had that agreement in the beginning, it makes it a little easier to gain entree.
I love that. And I think it's especially important regarding the earlier comment, if what happens if a preceptor doesn't take the initiative to bring it up themselves. So here's an excellent way that you as the student can take initiative and make sure that you will be heard later on in the rotation when these incidents happen. Thank you for that comment. All right. Okay, so thank you all for your engagement. So we'll move right on. So I think you all brought up some excellent suggestions, perhaps even better than the ones I have up here, but hopefully this will synthesize some of the concepts and ideas that we just talked about. So just to emphasize again, at the institutional level, institutions really have an ethical obligation to address this issue and to ensure the safety and well-being of everyone who works within that institution, including not only students, not only trainees, but also faculty members, staff, anybody who works within their institution. And so one way to think about how institutions can best support us in this endeavor is to think about how they can support each of these groups. Patients, clinicians, and the organization as a whole, how can we provide support to each of them? So for patients, we can provide patients with guidelines around conduct. These kinds of guidelines could proactively communicate expectations for patient behavior, as well as the institution's commitment to diversity and the no tolerance policy. So this information should ideally be made to all patients before they request an appointment, so that in a sense, they know what this institution stands for and they know that this kind of abuse or behavior will not be tolerated. For clinicians, like so many folks have said so far, we really need organizational-wide efforts to educate them on their rights and responsibilities, and also how to respond or de-escalate situations of discriminatory patient behavior, as well as how they can support their trainees in these situations. And at the organizational level, we need to develop clear policies. This is something that's come up throughout our conversation, and I've seen it several times in the chat as well. How do we develop those policies to protect clinicians from patient bias? How do we create a reporting mechanism for violations, as well as a feedback system to actually turn those reports into real change? And how can we create systems for adjudicating blame between the patient and clinician? That last one there is to get at the subtle nuance that there can be certain situations where a clinician's behavior may provoke patients to behave in a certain way. Not very common, perhaps, but it can happen. And alongside supporting patients, clinicians, and the organization as a whole, we really need culture change. This is something that's been brought up as well, is we have to commit to cultivating the kind of culture that allows people to feel safe. And in doing so, it normalizes reporting and supports clinicians. Over and over again, in today's discussion and other discussions I've had, I've heard healthcare professionals, especially trainees, express feeling worried about how is reporting going to affect my career prospects? How is it going to affect my clinical evaluations? And we have to work towards changing the culture around this. We know these incidents happen. It's not a question of whether they're happening. They are happening. And now it's about creating a culture where clinicians feel supported and safe. And finally, there's a lack of systematic research on this issue. There's very little that's been written about this in literature at large, and even little written about it from a systematic research perspective. So we do need further investigation on what are the causes and impacts of biased patient behavior, and what are the successful interventions that can be implemented when they occur. But, the lack of research should not hold us back from implementing everything we've talked about today. We know this issue is prevalent. We know how it affects everybody involved. And we have a real opportunity to move the needle on this. And I'll just conclude by saying that this is a very multidisciplinary issue. It's a thorny, complex one, and it's one that requires all hands on deck. It's not something that should be left to one particular group to figure out or solve on their own. It's something where we all need to come together to the table, come together to events like this, where we can have an open, honest, vulnerable conversation, and really start doing the difficult things, and making the difficult changes necessary to make sure that we can eliminate patient bias and discrimination within the clinical environment, and protect our students, our trainees, our faculty working in health professions education from these incidents and the ramifications of those incidents. And with that, one more slide here. So if you would like further information on this topic, so I've given you a flavor here of the frameworks that we talked about, that we developed, Dr. Jane and I, and we've spent around 2 years now on this work. And this piece that we published in Academic Medicine, it's a long one, but it really tries to get at a lot of the nuance that I can't capture in an hour and a half talk. But if you're interested in this topic, and I hope you are, and especially for the institutional leaders in this room, I'd encourage you to take a look at this piece and use it as a jumping off point to create the change that we need to create at the organizational level. And next slide. With that, I'd like to thank you for your time. Thank you so much for engaging in this discussion and participating so well. Thank you for everybody who was able to partake in this from various campuses, various settings, virtual and in person, and different health professional schools. This is the first event that I've been at that's been so interprofessional, and so integrating so many different parts of the leadership structure. So this is really exciting to see, and it's exciting to see so much interest in this topic. And I hope you came away with some nuggets that you can take back to your day-to-day practice, and also to your goals for long-term change. I have a few more minutes for questions, so I'm happy to take any questions that you have right now. Feel free to connect with me either on Twitter, or I'm going to put my email in the chat too so that you have it as well. But feel free to unmute yourself and ask any questions that you might have in our remaining time together.
So before we go to questions, Pooja, we want to thank you so much for being here. And we really hope at some point in time you will come to visit us here in Maine in person and come and meet all the wonderful people who work here. And I also want to very much thank Dean McCarthy for sponsoring this event, for the Medical College also, and to Ed Silva for your support and guidance on this. But this was terrific, and I'm watching the chat, and the thank yous and are just pouring in. So thank you so much for being here.
Of course. Thank you so much for having me and for creating this space to talk about this very important topic. I would love to visit Portland, Maine. I will take you up on that offer.
Well, I can give you that offer, but I think Dr. Herbert would also love to extend that invitation as well, as will Provost Pardue. So thank you so much.
Of course.
Thank you. Absolutely. Thank you very much, Pooja. It was terrific.
Thank you.